Okay, we'll just crack on, seeing we're running a little bit late. And I'm going to talk about, I have pressed it, all right? Go forward, that's what we want. I'm going to talk about the use of echocardiography and how it is important to you as surgeons. Echocardiography, of course, has become the most dominant tool in terms of the investigation of patients with congenital heart disease. And as pediatric cardiologists, I think, although the interventional catheterizers are very active and catheterizing for interventional procedures increasingly, in diagnostic terms we're using catheterization less and less, and the echocardiogram is becoming more and more important. So as surgeons, you've got to be able to understand the echocardiogram and be able to interpret it very easily. I'm going to talk about the several modalities that we use in echocardiography, and they fall into really three categories. Fetal echocardiography is important and I think will impact in the future on congenital heart disease, because you can make diagnosis of congenital heart disease from as early as 14 weeks gestation. Transthoracic echocardiography is useful in neonates for diagnosis, and in children, of course, for diagnosis and follow-up and post-operative follow-up. Transesophageal echocardiography is very important for perioperative care of children with congenital heart disease, and also for the investigation of adults with congenital heart disease, where transthoracic echocardiography is more difficult. And just to give you an example of the sort of ratios of echoes we do, the sort of numbers that we do, during 1995 we did something like 5,500 echoes in our department. It's now over 6,000, but a small percentage of these only were fetal echocardiograms, and a small percentage transesophageal echocardiograms. But these are significant percentages. Quite a lot of the fetal echocardiography actually takes part in the obstetric department. Part of the evaluation of the ultrasound evaluation of every pregnancy is to look at a four-chamber view, and here we see an example of a nice normal four-chamber view with the spine posteriorly. These are the lung fields on either side of the mediastinum and the descending aorta. And looking in the anterior thorax, you can see clearly two atrial chambers, two ventricular chambers, with in the moving image the mitral valve and the tricuspid valve on each side of the ventricular septum. And you can see the morphological characteristics of the chambers. You can see everything in very fine detail. Here's the right ventricle with moderator band, for example, the differential insertion of the two AV valves at the crux of the heart, and so on. So you can see the heart in very fine detail during pregnancy. So of course you can readily recognize when there's malformations present. Here we see an example of a very small elastotic left ventricle in the setting of a hypoplastic left heart syndrome. There's mitral atresia. There was also aortic atresia. We can see that the right ventricle forms the apex. So this is an easy diagnosis to make. And although it's only made in about 50% of pregnancies where the fetus has hypoplastic left heart disease, it's increasingly detected prenatally. And this is one of the commonest malformations we do see in fetal life. Another malformation readily detectable in the four-chamber view you see in this panel here. This is an atrioventricular septal defect. You can see the ventricular component, the atrial component, the common AV valve, and the characteristics of it very clearly in this fetal echocardiogram. And this, of course, is characteristically associated with Down syndrome, as it was in this fetus. Now, the ultrasonographers and obstetricians are becoming increasingly efficient at looking at the four-chamber view, and they're also learning to look at great arteries. There's no reason why they can't learn to look at great arteries, and some of the best ultrasonographers are able to detect malformations of the great arteries very easily. And here are two examples. Here we have the aorta overriding the crest of the ventricular septum in the setting of tetralogy of Fallot prenatally. And here we have a very nice example of transposition of the great arteries, where you can clearly see that the right ventricle is connected to the aorta, which gives rise to the aortic arch and the head and neck vessels, whereas the pulmonary artery is connected to the left ventricle. So clearly simple transposition in this fetus. Now what about in in neonates, how do we use the echocardiogram in the neonate? Well, we can use the echocardiogram to give us a complete anatomical diagnosis, particularly in infancy. We would prefer to avoid catheterization in the infant. That's where morbidity lies in terms of catheterization. In most cases, it's not necessary. You can make a complete anatomical diagnosis. And here we have an example of a complex form of congenital heart disease, where almost in this single frame, we can see all the components of the malformation. The apex points to the right. There is a common atrioventricular valve with a atrioventricular septal defect. Both great arteries arise from the right ventricle with the aorta anterior to a stenosed pulmonary artery. So although this is a complex form of cardiac malformation, all the details can be seen echocardiographically and outlined very clearly. We can use the echocardiogram to direct or plan infant surgery, and most forms of congenital heart disease don't require any further investigation because the surgeon can see clearly from the echocardiogram how to approach the child surgically. And here we have a nice example of an interrupted aortic arch. We can see here the pulmonary artery connecting through the ductus arteriosus to the descending aorta, whereas we can see this small anterior ascending aorta which branches nicely into these two head and neck vessels. And this is a typical interrupted aortic arch type B of a standard type, and this is sufficient information for the surgeon to be able to plan surgery without any further investigations. Here's another example of a complex form of heart disease, but the only information the surgeon really needed at this point in time was the side of the aortic arch. This patient has double outlet right ventricle with pulmonary atresia or critical pulmonary stenosis. The child needs a shunt in the early days after birth. So the important thing to be able to tell your surgeon is that the arch is left-sided and that the right side is the appropriate side to go in to form the shunt. Now, if we take transposition of the great arteries as an example of congenital heart disease and how the echocardiogram can be used to make the diagnosis and used to sort out the case and make sure you're making the right surgical decisions, we'll take transposition of the great arteries as an example. And here we have a neonate with parallel arrangement of the great arteries, with the pulmonary artery arising from the left ventricle, the aorta arising from the right ventricle. The ventricular septum appears intact. There's a large arterial duct, but there's a normal aortic arch. So it looks like a straightforward case of transposition of the great arteries. In another frame, we can see that the branching pulmonary artery is arising from the left ventricle, and although there's some turbulence in the pulmonary artery, this is coming from the duct, and there's no turbulence across the pulmonary valve itself. So the pulmonary valve is nice and normal, and this patient looks suitable for switch surgery. We can also use the echocardiogram for intervention if it's necessary in the first days after delivery. Sometimes it's necessary, as it was in a recent case where a fetal diagnosis of transposition of the great arteries had been made, but the atrial septum appeared intact in utero, and so immediately after delivery we could see that the atrial septum was restricted. There was a very small atrial septal defect, and so we used the echocardiogram to perform a balloon atrial septostomy prior to switch surgery, which was planned for a couple of days later. So thus the echocardiogram is used in management. It's also used to decide whether switch surgery is appropriate. Here we have a case of transposition VSD, but there was some subaortic tissue underneath the pulmonary artery which was attached to the mitral valve, which made the child unsuitable for switch surgery. Similarly, in this patient over here, there's subpulmonary stenosis and a large subpulmonary conus. The pulmonary valve itself was dysplastic and doming, and there was a ventricular septal defect. So this again was another case of transposition where the echocardiogram could demonstrate that the patient wasn't suitable for switch surgery. What about the coronary arteries? We can certainly look for the coronary arteries echocardiographically and usually can be accurate in predicting their position. Here we have a neonate with normally positioned coronary arteries. Here we have a single coronary artery with the right coronary artery coursing in front of the aorta, arising from the single left coronary artery. Here we have left main coronary artery with the circumflex coronary artery arising from the right coronary artery, so it courses behind the aorta. And here we have an intramural coronary artery where the two ostia were very close together, and the left main coronary artery ran between the aorta and the pulmonary artery. Important for the surgeon to know when he's planning a switch repair. So what about children with congenital heart disease? Most cases of uncomplicated malformations in children can be assessed echocardiographically and don't need further information apart from clinical information in terms of timing your surgery. But echocardiographically, in this case of tetralogy of Fallot, we could see all the details that the surgeon needed to know for surgical repair. Similarly, in an atrioventricular septal defect, we don't need invasive information. And even in a case like this, where we have a coronary artery that appears to be arising from the aorta, but the child presented with symptoms suggestive of an anomalous coronary artery, when we put the color flow map on, we can see that there is reverse flow in this coronary artery. And this indicates that, in fact, this coronary artery is not inserting as it looks like it's inserting into the aorta. It, in fact, ducts down at this point here and inserted into the pulmonary artery. But it was the color flow map that gave us the clue to this diagnosis and, of course, the clinical status of the patient. But even in a complex case like this, the diagnosis can be clearly delineated echocardiographically. And just out of interest, we looked at some of our cases that were going to surgery, and we looked at our series during 1996, where we did 438 surgeries at Columbia Presbyterian. And we noted that only 89 of these patients had required preoperative caths. About half of them were less than a year, and very few of our cases were recatheterizing in the first month of life. And in the general terms, the preoperative caths that were performed were all to look at pulmonary artery pressure in the pre-Glenn or pre-Fontan situation, or to look at branch pulmonary anatomy where it was in doubt in terms of surgical repair. So transesophageal echocardiography is our last modality to think about. We use it for the evaluation of adolescents and adults with congenital heart disease. We use it in the immediate preoperative evaluation and confirmation of transthoracic findings, and for the preoperative evaluation of the repair, just as the surgeon is starting his case. It's particularly important to look at, to apply transesophageal echocardiography not to every case that's in the OR, but particularly to those cases where valve repair or replacement is taking place, to look at patch integrity after VSD closure, and to look at function when after you're coming off bypass. In a series of 200 studies, we looked at critically at our use of transesophageal echo over a 15-month period, and we found that its use was critical in 4 patients, its use was very helpful in 12, it was useful in 66, and it really didn't have an impact in the management of the case in just over half the cases. But I think that says more about the quality of the surgery rather than the transesophageal echocardiography modality in itself. But in the considerable number of cases where it was useful, I think we should persist in using it in a large number of our cases. Here's a couple of examples where the transesophageal echo was important. This patient had an AV canal repair, but as the patient was coming off bypass, it was clear there was still pretty severe mitral regurgitation. And in fact, when the surgeon went back onto bypass to look at the mitral valve, stitches had come loose on the mitral valve, cleft area, and after repair of that, when they came off bypass the second time, there was very little mitral regurgitation. So this was an important application for your transesophageal modality. Here's another case where the transesophageal echo was important. This patient had a PA band placed in the setting of transposition of the great arteries, preparing the left ventricle for a two-stage switch procedure. But when the band was placed at first, the left ventricle began to dilate and look rather dysfunctional. As the band was loosened, left ventricular function returned, and the band could be kind of titrated according to the appearance of the left ventricle so that exactly the right amount of constriction was made on the pulmonary artery band. Lastly, echocardiography is used for post-operative follow-up, and of course that sequential takes place over many years after follow-up, and of course there are lots of situations where the echocardiogram points out situations where re-repair may be necessary. A nice example we see on this panel here, where this patient has had a mustard repair for transposition of the great arteries in the early 80s, and here we have the common site of obstruction of the pulmonary venous baffle between the pulmonary venous atrium and the collecting of the pulmonary veins and the connection across to the morphological right atrium. And at this point it often becomes obstructed. Here you see accelerated flow across this site, and this was a real obstruction to the pulmonary venous baffle, and important for the surgeon to return and refashion this area. So just to summarize, the use of echocardiography in congenital heart disease is absolutely vital. It's an important diagnostic tool both in the diagnosis and sequential management of the child with congenital heart disease. It's important that if you're going to do echocardiography in children, you must have the best resolution equipment, you must have a wide range of transducers for the different modalities of echocardiography, and you'll get your greatest accuracy if you're working in a lab with a high volume and performing pediatric cardiology full time. Now, Jeff asked me to talk just a little bit about some new areas in echocardiography to touch on, and it was rather difficult to know just what areas to mention. Of course, there are some new areas of echocardiography that are changing and that I think will impact the future of congenital heart disease, and I've chosen just a couple. The first thing I've chosen is early fetal scanning, and I think this will have an important implication in the future. What we can do using transvaginal high-resolution ultrasound is to look at the cardiac anatomy as early as 14 weeks gestation. And here we have an example of a 4-chamber view in a fetus at 14 weeks gestation. You can see the centimeter marker here is 0.5 of a centimeter, so the whole heart is about 0.5 of a centimeter, so it's very tiny. But despite that, you can see the 4 cardiac chambers. You can see flow through both atrioventricular valves. When you turn into the long axis views, you can see the ascending aorta, although it's a very tiny structure. It's about 1 millimeter, 1.5 millimeter at this gestational age. And you can also see the relationship of the pulmonary artery to the aorta. That is normally connected great arteries. Now, of course, if you can see normal cardiac anatomy, you can also see abnormal cardiac anatomy. I think the important implication from this is that in common with other malformations that are detected very early in pregnancy, at this stage where the pregnancy is still not as obvious as it is later on in pregnancy, and the mother is not feeling movement at this stage, and so on. Malformations that are found at this stage, particularly if they're associated with chromosome abnormalities, the parents are much more likely to choose to interrupt a pregnancy where there's a malformation found very early than they are later. So I think this is something that will have an impact on congenital heart disease over the longer term. Another area of growth and change which I think will become important, and I'd like to thank Jerry Marks, who's now at Boston Children's Hospital, for borrowing these slides, is the use of three-dimensional echocardiography. Now, in the early days of two-dimensional echocardiography, I remember very well because I was a fellow at the time, everybody said it would never catch on, it would never be an important modality. And when we first saw the 3D pictures, we were all sort of saying the same thing. I'm sure that's not true. I'm sure the 3D pictures will become very important. I think they will become more understandable as they improve in resolution. They get better every year. Every time I see Jerry's slides, they're better than the year before. I think in a few years' time, they will be such that they're going to be the modality for echocardiography, and we're all going to need to have 3D equipment. And these are just two examples. Here we're looking at the right ventricle en face, and we're seeing a primum atrial septal defect in this position here, just as if you'd taken off the front of the right ventricle, of course, and we're looking at the heart from the surgical standpoint. And I think surgeons in particular will start to find this modality more attractive because it gives you much more of a three-dimensional view, the kind of view they're used to looking at in the OR. And here's a membranous ventricular septal defect seen from the left side of the heart. Here we have it here with the aorta in this position here, and you can see that you can measure it very nicely and tell the dimensions much better than you can in the two-dimensional frame in this three-dimensional image. So I'm going to stop there because I'm sure we're running over time. Thank you for your attention.